Everyone, and welcome to today's session on hidden agenda in obstetric stations, to be followed by another session uh, by Dr. Alina. So, on the behalf of the Med Exam Expert Group, I welcome you all to this evening. I am Dr. Pooja Dimri. I have been teaching for the Part 3 courses with Med Exam Expert for the last 4 years. And I'm very happy to be here. And I see a lot of participants have joined today. We all know that the Part 3 exam is a communication exam. And so today, I will start. I wanted to discuss this topic of hidden agenda because this is something we all are worried about when we go for the exam. And actually, we start imagining that there is a hidden agenda in every station. Please mind it, it's not so. You might have one of these stations which has some underlying thing which you need to decipher, but usually there will be something in the question or in the behavior or the conversation of the role player which will guide you. The most important thing to bring out the hidden agenda is your communication. So I'm going to do 2 stations, around 20-25 minutes each. Both these stations are mainly based on communication. And this kind of stations will be having a lay examiner. Please remember that. So the lay examiner means that you are marked on the same station by a clinical examiner who's a doctor and a lay examiner who is a lay person, but who will mark you on the same domains of patient safety, communication with the patient, and how's your knowledge about the subject. And these kind of stations, you all know, will carry more marks or more points. So it's very important for us to be very well versed in these kind of stations. And the only way is to practice them, to be able to communicate and converse fluently at the time of station. So you will have to practice it earlier, because these kind of scenarios, if you have not practiced, become very difficult in the exam. On the other hand, if you have practiced them, they're easy to do because there's not much of knowledge you require, or it's more of how you communicate. And by communication, I mean, how do you ask those sensitive questions? And then how do you empathize with the patient and give the patient support? So when you are asking questions, you have to be very sensitive. It's very important. And the empathy should show in your voice, in the tone in which you are talking, and in your expressions. So you should remember that if your communication lacks these features, suppose you're not very sensitive in asking questions, or you are sounding, unperturbed by the situation, or you're sounding very indifferent, then the role player might not give you the correct information. And in spite of you knowing what the scenario is, in spite of you knowing very well what is underlying there, you may not be able to elicit the history. And unless you elicit the correct history from the role player, you are not able to explain the management or to communicate well. This was very well shown in the RCOG recap course, which I did when I went for the exam. And similar case of a hidden agenda and the candidate knows, and it is evident from the question what the hidden agenda is. But because the communication skills were poor, the role player never came out with the correct lines or correct answer, did not bring out her actual problem. And then, unless you can bring out the actual problem in the information gathering, you cannot explain the management. So it's very important that you communicate well in these stations. These stations are nothing extraordinary. They are very common scenarios which you will find in the exam. Now we are going to see how you're going to express yourself and how are you going to deal with such stations. And it comes with practice. So that's very important. After today, you should practice the same or similar stations with your friends or with your study partners and see how you can improve and give good feedback to each other. So we will start with the first one, and I will invite some of you candidates to, you can write in the chat who would volunteer to do the first station with me. I'll be doing 2 stations. Later, Dr. Alina will join us, and she will be doing one teaching station and one general gynae station. That will be later. So you have a good 4 stations today. So I'm looking at the chat. Anybody who can volunteer for the first station? Dipali. Okay, first Dipali and second is Ahmed. So I will start with Dipali. Okay. Hello, Dipali.
Hello. Hello, good evening,
Hi,
Dr. Pooja.
Hi, good evening. So where are you joining us from?
I'm from India only.
And where in India?
I'm from Delhi.
Okay, good. I'm also from Delhi, but right now I'm talking to you from Singapore. So good to see Delhi at least in the Zoom call today.
Yeah.
Okay, so again, like the MRCOG, I'll be giving you 2 minutes reading time. So in the 2 minutes, you think about how it's not rocket science, this station. It's a very simple one. So you use your 2 minutes to write down the points or type the points, because nowadays people are typing more than writing. So do that, and as in the exam, what would you like to ask and what would you like to tell the patient? So do that. And this is for everyone, everybody who is here in this session. Please use your pen, paper, or your laptop to type in or write in your points as you would do in the exam. It's for everyone. And later on, once the station is presented, you see what you can add on, what was missed, and what was missed by the candidate, what was missed by you. So, and then we will go on and discuss it. Okay. So 2 minutes station time and 2 minutes reading time and 10 minutes station time. So let me just put on my clock. Give me 1 moment. And I will be projecting your station for you.
Okay.
Okay, your time starts now. Okay, 10 minutes.
Okay. Hello, I'm Dr. Dipali. I'm one of the doctors at the clinic today. May I know your name and age, please?
Hi, doctor. I'm Abigail. I'm 34.
What would you like me to call you?
You can call me Abigail.
Abigail. Abigail, you can call me Dipali. So, Abigail, I have been told that you are currently into 32 weeks of your pregnancy and you are having pain in the tummy. Is that right?
Yeah, doctor, this pregnancy, since the beginning has been really problematic for me, and this pain keeps happening. I come to the hospital, then, they tell me there is nothing. I think I always feel I'm going to labor, something will happen to my baby. So again, I'm feeling this pain since one day, since the morning, I'm very uncomfortable.
Okay. Have you been experiencing this problem before?
Yeah, I had come a couple of times earlier, and then once they had admitted me, they did test and ultrasound for me, and then said everything is okay and sent me home. And now again, this pain is happening. I don't know what is happening.
Okay. Abigail, I'm going to ask you a few questions regarding this pregnancy. If you don't mind, then we can go ahead and discuss the plan with you. How does it sound?
Yeah, okay, doctor, that sounds good.
Okay. Thank you, Abigail. So, can you tell me about this pain? How long you have been experiencing this pain? Any tightening in the tummy you felt?
Tightening happens like 2, 3 times in a day, but this pain I feel more since morning. Though I keep on having some aches and pains. I was told it is normal in pregnancy, but now
Okay.
I can't. Today it is quite bad, doctor.
Okay. Are you having your normal fetal moments?
Yeah, yeah,
Okay.
yes.
Okay. That's great. Any discharge from down below? Any bleeding?
No, doctor.
Okay. Uh, uh, is this your first pregnancy?
Yeah, this is my first pregnancy.
Is this the planned one?
No, doctor, it was quite unplanned. Yeah, but then ultimately I had to become pregnant, so I just continued with it. I have diabetes also, and that
Yeah.
also is another issue, and my sugars were also not controlled, but then I decided to continue.
Okay. How are your sugars right now?
Now the doctor is increased some insulin dosage, so last few days it was okay, but I have not been checking very regularly, doctor. It, that,
Um,
no, there's so many times you have to check in a day. It is very difficult for me.
okay. Whom do you live with, Abigail?
I live with my partner, doctor.
Okay. Uh, so does your partner helps you with sugar monitoring or managing your diet, anything like?
Oh, he's very busy, doctor. He goes to the office in the morning, comes in the evening,
Okay.
so he cannot help me.
Okay. Okay. So what about your pregnancy? Is this otherwise, apart from this diabetes, what about your previous test, ultrasound? Are they all normal?
Yeah, so doctors tell me that everything is okay, but I don't know why I keep having this pain. They said other blood test was okay. They did a ultrasound scan for growth of the baby, and they said baby was growing okay.
Okay.
Yeah.
Uh, any other thing you're following up with your GP? Any medicine apart from the diabetes? Any medical disease? Any surgery?
No, doctor, nothing.
Okay. Because please don't mind me asking, do you smoke?
No, doctor.
Any alcohol and drugs?
I used to take alcohol before pregnancy, but I stopped. No drugs.
Okay, that's right. Abigail, do you work somewhere?
I was working before pregnancy, but then because of this diabetes, and then you have to check sugars hold all day, I could not cope. So I left my job.
You told me that your partner is busy, but otherwise, when he is at home, is he supportive otherwise with the pregnancy and with the environment? Do you feel okay at home? Do you feel safe at home?
What do you mean, doctor?
Do you get friendly environment at home, or do you feel stressed, or are you scared at home that your partner will say something to you regarding this pregnancy?
Mm, he's been okay, doctor. He's been busy, and I have so many problems. I'm getting pain, and um, I don't know, doctor.
Okay.
I'm not
Abigail,
able to cope. Yeah.
okay. Abigail, let me tell you this, that you can, first of all, you can tell me anything. I won't be writing anything on your notes. Whatever you tell me is going to be between me and you only. I'm not going to disclose this even to your GP or to your partner. I should also tell you that the many women, they experience domestic problems, domestic violence. Approximately 1 out of 4 women in UK experience this, and it's your right to get help. If you're not safe at home, it's going to be very unsafe for the baby also. So do you feel safe with your partner?
It's okay, but sometimes he gets very angry, doctor. Maybe he's very stressed at work, and I'm also talking about all the problems I'm facing in pregnancy. So yeah, sometimes he gets very angry.
Okay. Has he ever hit you?
Um, yes, doctor, once he did hit me, but then he apologized.
Okay. When he did hit you, then did you told it to any of your friends, any family members? Do you confide with anyone?
No, doctor, I didn't. I thought it was because I made him angry and it was my fault.
Uh, Abigail, whatever problems the partner and the but whatever problems with you and your partners have, it doesn't give him any right to hit you anyway. You have the right to feel safe in the pregnancy, to have safe and the healthy baby, because if he hits you continuously, or if we do, it can be really unsafe for the baby at times. So I believe you should talk to somebody in your family. If you want, then we can help you. If you uh, do you feel for your life at home? Do you feel safe to go home now?
Hmm, I am not sure, doctor.
I can help you, because then we are going to involve some safeguarding teams of the hospital. Um, if you want to report it to the police, we can help you in this also. If you
No, no,
don't
doctor,
want,
I don't want to report to the police. No, I don't want to go to the police.
okay, Miguel. But I would advise you that you talk to somebody in your family, like friend or somebody family member. You keep a bag ready at home where you can have a mobile number, any helplines. There is a domestic violence helpline where you can contact an emergency in case you feel threatening for your life, that you are if you feel that it's really unsafe and you have to get out of the home, so keep the stuff ready and you can call the helpline. They're going to it's already, although it's on the working hours only, but they are going to help to get you out safely out of the house. If you want that during the next appointments also, if you feel that you have to talk to someone, we can, there are the urine stick P's where you can put a color sticker that you need to help right now, and we immediately know that you need help right now. Most of these services, they're going to help you, although they don't support you financially, but they can help you to at least have a safe and healthy delivery so that your unborn baby is fine.
But I don't want to leave my husband, doctor.
That's fine, but it doesn't give him any right. It's your right to have a safe home, and your right of your unborn baby to have a safe life. Because if he hits you, it can really harm your baby. Sometimes this continuous problems and hitting can, your baby might die in the womb. It can be really stressful, and if he hits directly on the tummy, it might happen.
Yeah, you're right. Uh, can I think about it?
Yeah, sure. So I'm not going to write anything in your notes, but I'm going to write in my hospital paper. You can also, I'm going to give you one leaflet which you can fold and put it in your purse. It's very small leaflet. You can keep some numbers ready at home. You can keep one mobile phone, keep it in the silent mode, keep it at your home at the safe place, so that if you need to get out of the house safely at any time of the night, you can do so. Confide in one or two of your friends so that they can come and help you in need. If you need any help in the hospital, we're there to help you.
What about my pain, doctor?
Yes, I'm going to do an ultrasound scan now. I'm going to give you one or two
Okay, time's
painkillers.
up.
Thank you.
Okay, so Deepali, how was it?
I think time management, and I forgot few questions which were really relevant. Allergy and
Like,
BMI.
okay,
Uh, his,
what else?
History of allergy, history of BMI. Then I forgot family history. I
But
could
if
have,
you had asked, if you had asked this history, what about the time management then?
yeah. I spend more time on a little bit on domestic violence counseling. I spend more time on that.
Okay, how was the communication with the patient, do you feel?
Um, I, I don't know. I believe I bought out the uh, hidden, like she was hiding the concerns that she's being hit one times, and I bought out the history. And at the end, she told that she wants to think about it. So I negotiated my way out of it. Uh, and I gave her safe options which she can follow at home. I don't know that.
But you didn't take her pain seriously.
Yeah.
So that's one important thing. Of course, we are looking at the hidden agenda, but we should not forget the agenda. So
Yeah.
basically, yes, she may actually be going in preterm labor. So
Yeah.
we should not forget about it. So okay, I'll first ask somebody else to feedback you. Let's see, a lot of people are okay. Uh, Sayam, Sayam Dhama, you there?
Yes, Dr. Pooja. I am Dr. Vanna.
Sorry, your
Yeah,
doctor?
it's my son. Yeah, I am Dr. Vanna Dhama. It's name of my son.
Oh, okay, okay, Vandana. So, what is your feedback for Deepali? Your positive
Uh,
points, negative points, anything you want to add?
uh, Positive points. Her communication skill is good, and
Okay,
yeah, and only lacking of few points in history. Like
okay.
because patient has 32 weeks, so we can ask blood group also, and any reservation for blood transfusion, like that.
Mm-hmm.
And yeah, good point. She identify hidden agenda also, and
Okay.
yeah, and lacking point, we did not take the history of diabetes. How will we explain the patient to monitoring of sugars? And we should offer the patient admission, because she told us she is not monitoring her sugar in a very comfortable manner. Then we should
Mm-hmm.
see how is her level, and we should
Okay.
examine the patient, because we did not examine the patient. We should also do the general examination as well as per abdominal examination. And she may be the case of preterm labor, so we should do the perispeculum examination also,
Okay. Good. Okay.
or per vaginal examination if we are unable to see the dilatation of the cervix.
Okay. Okay. Uh, I go to somebody else. Ayan.
Hello.
You.
Yes, Dr. Pooja.
Hello. Hi, Ayan.
Yeah.
So, anything else you want to add?
Actually, she did quite good, but I was just feeling that while she was doing the counseling,
Mm-hmm.
there were some things which she was repeating. So that's why there was a waste of time in that. She could have
Mm-hmm.
cut shorted that to be very focused, that if she's feeling unsafe, we have to offer her admission right now. And then
Okay.
we can discuss with her that we have specialist nurses here who are very trained to discuss with the patient and give them a safety options. And then the rescue plan, which she discussed with her, that if you want to go back, we can give you rescue plan, how you are going to manage all these things. She discussed, but she did these things repeatedly. That's why she just lost time. And rest
Uh,
of the things which she was discussing, like preterm labor, yes, it is important. We would have asked her when she had the episodes of admission previously, what treatment she got, and what is her endocrinologist opinion about her diabetes control. And obviously, if she's going through preterm labor, then we have to admit her, we have to give her steroids, and we have to monitor her labor, and we have to discuss the delivery plan as well accordingly. So that's why we have to involve the multi-speciality people as well to look after the management of the preterm labor as well as going for the domestic violence together. So that is two things in this station which need attention and counseling.
What do you think about you asking about blood group, acceptance of blood transfusion and all? Would you be able to ask these questions in this station? I'm just asking
Dr.
a practical
Pooja,
thing.
yeah, actually, if like one thing which I have noticed earlier that most of the mentors, they say that when you ask for like medical surgical history, the only thing which you should be very straightforward, do you have any other things which you are seeing your GP? That is enough. We don't have to ask whether you are going hypertension, diabetes, clot, because if you go use these words, we will be cut short of time. So similarly, like blood group, yes, we can ask, because if she's going through preterm labor, we don't know what is the mode of delivery we are going to offer her. She might need blood transfusion. So that is a relevant point. But as well as, you know, the woolly questions regarding the depression and mental stress, that they should also be asked in this because if we are going for domestic violence, obviously she will be stressed and depressed, and we have to ask all these questions as well. But
so
as you said,
just to add, just to add to this point which you said, which was very correct, the hidden agenda could have very well been depression in this case, rather than domestic violence. So,
yes, it could be.
It was not asked. Yeah. So we do this type of questions, definitely asking about depression and anxiety. The questions, the two questions you ask, very important. Very correctly. That's very important, because it may not be. So that's why I'm saying we should not be blindsided by what is given. Of course, the question gives you an idea. She has repeated admissions, then you do think, but that can be even in a depression patient. He keeps coming, complaining of pain, and keeps coming to the hospital. So yes, the mental health is important. And secondly, I would offer her a psychological counselor also at this point of time. She looks depressed.
Definitely. Yes.
Okay. In the part of the management, when we are talking about management, of course, she came out. Of course, Deepali, I think, communicated well, and the patient did bring out her the hidden complaint of domestic violence which is happening. So, but when we are talking about management, she definitely needs some counseling as well. Not only the safety part of it, but the mental health part of it. Because in this scenario, patients may, they may commit suicide or, harm themselves. So mental health question are very, very, very important in this kind of scenario.
And Dr. Pooja, sorry.
Yeah.
Just one thing which the other doctor also mentioned, that you have to ask from the drug allergy, because if she's in preterm labor, we are going to offer her medicines. So we have to rule out the allergies, the patient safety point, which should not.
I think drug allergies drug allergy without fail has to be asked in all the sessions. But you have to be fast. Somehow you have to incorporate a lot of points. I understand this is a complicated case. It will not be simple to ask questions, also getting information. But some things, yes, you need to do, like allergy, because you need. So in this, there are two parts of the management. One is three parts, I would say. One is the pain, which she has presented with. So she might be having abruption. She might be having preterm labor. So we should not neglect that point. Of course, that is what happens. You decided that it is domestic violence, which it is, but you have to you should not forget about the obstetric part of it. We should not. So this was good that Deepali asked about fetal movements, watery discharge, bleeding, and all. But pain, you could have asked more, like what kind of pain it is and what was taken. And then I would like to examine you. You have to see her for contractions. You may have to do a CTG to check the baby's heartbeat. Okay, she's contracting or not, and maybe do a speculum examination to check whether she's dilated or not. So that's important. So we should not neglect the pain part of her. Second is her diabetes, which she says she's not testing properly. She's on insulin, metformin. She's a type 2 diabetic. So very important, the diabetic management. She may have a IUD if her sugars are very uncontrolled. So you can ask her. So offering her admission would be good at this point of time. You can offer her one that she's saying that I may not be safe. She's very dilly-dallying about it. So you can offer her admission. You can say that we would like to also monitor your sugars and see if you require a change in dose. Right? So you cannot forget about the diabetes also. So I know we have to, the obstetric management doesn't change, correct? She may need a scan now. She's a 32 weeks. She had scan sometime back, she says. So this might be the time when she needs a growth scan. So So you can offer admission for her safety. Plus you can say that we will also monitor your sugars, because your sugars, or if she doesn't want to get admitted, then you can say that that you have to emphasize that, you know, the sugar monitoring is important for you, because uncontrolled sugars can cause problems in the baby. So that also has to be emphasized, that she needs to, I know you can say that, okay, I know it's very difficult for you. You have to monitor very regularly and throughout the pregnancy, but that is very important for the baby. So I would advise you to monitor your sugars regularly, or maybe I will call you back in a week's time, or to meet the endocrinologist to decide about your insulin dosage and all. So the diabetes also is a part of it. The domestic violence part of it, which Dipali says, and then she says that she took little more time in that. I know it is not easy. Time management is the one thing we are always struggling with when we are doing these stations. So good points. Yes, you said confidentiality, which came later. So, but then you could understand, and then you said she was not bringing it out. Then you told about confidentiality. You talked about safeguarding thing. So you said that we will not put it in the held notes. That was fine. Then you offered her that one thing is, have you ever talked to anybody else about it? So you should assess, you know. So you can just assess, you are in contact with your parents, you have somebody in the family or your friends who you are close to, then, and then you, I think you emphasized 2-3 times, which wasted time. You said you should talk to somebody, but yes, the point was correct that she should involve somebody else who can help her. Then you offered her whether she wants to make a report, which she refused, but that's fine. You cannot do it against her will. Somebody has written about child, but there is no child involved. This is a first pregnancy, so there's no child which we are talking about. Of course, if you feel that a child's safety is being compromised, then of course you don't care about confidentiality now, then you have to involve the safeguarding team. But I would add the counseling bit, psychological counseling as well. So added points can be, of course, talking to her more and assessing her pain, and do an examination and maybe a CTG, arrange an ultrasound, management of her diabetes, and third thing, offer admission, which can take care of some few things, you know, just till she settles down, and then you can decide what is to be done. The rest of the things I think was fine. Okay. Anybody wants to add? One person can add if they want to say anything.
Yes, Dr. Pooja.
Who is this?
Sharma, can I add something?
Yeah, please do.
Yeah. One thing that, we can inform the adult that domestic violence, that adult security safeguarding in the hospital, if she, because she's adult. And but the children is not involved, so for the children we can tell about the social service to help her, and we can ask her for financial support also, because sometimes they are afraid for financial also. That's why she doesn't like to open her mouth. So financially she needs help or not. If need, then we have to reassure her for financially. Another thing that for escape plan, that to make her passport, driving license, money, and then spare key for the escape plan.
She did talk about that you keep a bag in which you keep your documents, is what I understand. She did talk about that.
Yeah,
you did, Dipali, correct?
Dr. Pooja. Hello, Dr. Pooja.
Yes,
I want to add one thing. Dr. Vandana. Dr. Vandana.
Yeah, Vandana.
Yeah,
Yeah, tell me.
Because Dipali said, I am Dr. Dipali, one of the doctor in clinic today. So there is situation awareness. Okay, the term situation awareness, and patient is in delivery suit. So can we say I am Dr. Dipali, one of the doctor in delivery suit?
Yeah, you should say that when it is written in the question.
Yeah, because it is written in the question delivery suit today. Because she came in labor room delivery suit, not on the outdoor clinic.
Yeah.
And
so
second thing,
and Dr. Pooja,
one person please finish. Otherwise, because I cannot see so many people, one person finish. Vandana, you finish first, and then we can.
Okay. Dr. Pooja, can we involve the MARC also, or we can say the independent MARC conference, multi-agency safe assessment conference?
That is more in sexual assault.
Okay. And we can involve the independent domestic violence advisor. We can use this term in this station.
You can.
Okay.
You can.
Thank you.
So
Thank you,
basically,
Dr. Pooja.
see, it will depend on how much time you have to use all these terms. I would say safeguarding. If you use the term safeguarding and social services, then you could talk about women's aid and refuge. These are the things you can talk about. Yeah, last point, Sharma was speaking. Quickly, because I have to go to the next station now. Last words, last thoughts. Dipali, anything from your side? I think you also understood that some of the points you missed, but I think it was a good effort. The communication with the patient was good. And as I was telling you, this was the similar station which was in that course, and they had shown us 2 videos actually. I'm talking about when I was preparing. And then one video, the candidate knew, it was like patient coming with multiple bruising and all, and you definitely think it's a domestic violence, but the candidate could not ask the questions very sensitively, and then till the end of the station, till 10 minutes, the role player did not come out with the history. So anyways, you cannot do that station unless he says, you know, I'm a victim of domestic violence. You cannot, even if you know. So that's an important point which you brought about. But yes, I think time management is important. Yeah. When you were using those 2 minutes, and then we were talking about situational awareness. So those 2 minutes, what you have to think, who are you in this scenario? So you are an ST5 resident, okay? Then where are you? So that tells you you're in the clinic, or you're in the emergency, you're in the delivery suite, or you're a menopausal clinic or cancer clinic or whatever. So that is where. And then what is the situation, this patient, okay? And what are you going to do? So these are the questions I know the 2 minutes also is a very short time. So when we are practicing, and when everybody, all of you who are listening today are practicing your stations, even when you are reading from the book, suppose you have a book in your hand, which is a part 3 book, and you are doing a station, because sometimes you just do the station, you just read it. The reading of that station also from the book should be 2 minutes. You have to time yourself. Because when you're reading a book, you have, you can keep reading it for 10 minutes, but you should not be reading it for 10 minutes. You have to read that full question in 2 minutes. Again, you write down, because that will give you the practice for those 2 minutes. And you all understand that those 2 minutes determine what you're doing in the next 10 minutes. Simple as that. Because you cannot think so much when you're speaking. You're talking to the patient, you have to think what you have to ask next. You are worried about the time, you're worried about the next station coming. So your mind has to be very attuned to that, what you have to do in those 2 minutes. So 2 minutes, you should be practicing each day, reading from the book or doing with your friends or doing with your study buddy or whatever. Those 2 minutes you should always use to write down what you are going to write down in that station. And similarly, all of you sitting in the session today, even if somebody else is presenting, you need to use those 2 minutes to write down. And later on, you should, feedback yourself. What have I written? Would I be able to do the station very well after what I have written? This is what should be your homework. So unless you analyze what you're doing, practice is also of no use. So you have to keep analyzing. So it's a good idea to, practice many stations, and this station comes in the exam. I will do it like this way. But there may be some stations which they have never come in the exam. There will be something new also. So how do we deal with those new stations is that your mind is already attuned or practice what has to be done, even if something new comes. So you have to practice this thing every time. Okay, so somebody has asked, when should we speak about examination before domestic violence history? So see, there are no hard and fast rules about when you should speak what. It is determined by how the conversation is going, correct? You ask something to the role where if she's talking about something, you cannot just in between say, I'm going to do the examination for you. Then you have to answer her, it's a conversation. Never think of the station as a lecture you're giving to the patient. It's a two-way conversation. You always have to respond to the cues of the patient, what they are saying. You have to respond not only in words, but your facial expressions, your tone of voice, especially this patient is telling you that she's getting hit by a partner. So You can speak at any time you want. If she was talking about pain in the beginning, you can say that later she talks about pain. You say that later, after I ask you questions, I would like to examine you. You can say that and examine you and check your tummy, check the baby's heartbeat and all. So at least you have done that point. Then you can go on, keep talking. But if there is no, if she's talking herself and there is no opportunity there, then you have to say later that if you're okay now, I would like to examine you. So it will all depend on what the situation is. Nobody can tell you now how the communication or the conversation is going on with the patient. So you have to change accordingly. You have to be ready to change. Yeah, so yeah, Sharma is saying not fair to interrupt. Okay. Are you saying it to me, Salma?
Yes, I didn't finish, but somebody is interrupt me and you told me to stop.
You can finish now. You just finish now. I gave you opportunity back, but I think we lost you. You can finish, yeah. Give your final, you want to add something? No, it happens,
Yeah.
it's a Zoom call. There are a lot of people here, so people cannot see who's speaking. So don't worry about it.
No.
You can finish your point, yeah.
Do you think that pain relief we can offer because she's on pain?
Sorry?
Do you think we can ask that she's on pain and to offer her pain relief if she has pain?
So basically you have to assess what kind of pain. So you can say that later, let me find the cause of your pain. Let me see whether you are having contractions. And then, because what pain relief will you give now? You don't know. So if she is having preterm labor, then you may have to give tocolytics and, give steroid or anything. So first thing is, you ask her how bad is the pain. If she says too much pain, you said that I would ask the nurse to give an analgesic, but let me assess what is the cause of your pain. So that is more, practical. Let me find out what is the cause of course, if she's holding her stomach and she's saying, oh, I'm too much pain, then you will say, let me examine you first. Okay. So I think that will be better, so that shows the examiner that yes, you want to know, because it may be abruptio placentae, then you cannot give analgesic, you have to do something. So you say that I would like to assess the cause of your pain, and if you will give me some time. But mostly the role player will not be, so much in pain because they have to talk through the session. Okay?
Yeah. And another point, the domestic violence nurse, there is a special domestic violence nurse. She can
midwife.
visit her also. Midwife. Yeah.
Yes.
Midwife.
So yes, you are right about. You should say that there is a team. Okay, there's a multidisciplinary team. Who will look after you. Yes, including the doctor, as you said, the domestic violence midwife, and then the counselors and all those people, and then if they are health visitors also later on, they can visit their home and find out. So they're health visitors. Yes. And if she wants to involve the GP.
As diabetes, she's uncontrolled, so we can ask her that last visit, her, with her consultant, she's following her consultant or when her last visit.
Yeah, so diabetes, so diabetes, she says she's not even testing regularly. So basically you have to emphasize that you need to control diabetes and monitor your sugar. So you have to emphasize that for her. That's what we talked about. Okay?
And financial support, which one I told, do you think we have to ask?
So basically social services, you just talk about social services. They will carry out the financial. So so basically you have to assess the social support. Yeah, you have to assess the social support, like, because she says she's not working. So you can say that everything okay at home, and then you say that if you want any other help, we can involve the social services who can talk to you and help you to deal with it. So that overall, takes care of everything.
Yeah, thank you very much.
Okay, sir. Okay, thank you all for your inputs, and thank you, Deepali, for being brave enough to take the station. It is an act of bravery, I think, to speak in front of so many people. So that itself is very important. That makes you more confident. Because when I was in your situation, I never used to present anything there. And it's true.
Thank you, Dr. Pooja. Thank you so much for the very, very important points I missed. But actually, I'll keep it in mind. I need to be more aware. Thank you.
Great. Well done. It's good if you can take feedback, and everybody should take feedback in a positive manner. All of us are trying to learn, and all positive and negative feedback is for your benefit, for everyone. So confidentiality, I'm just quickly telling you about some points I wrote about. And when is the confidentiality broken? When there is a risk, if you feel there is a risk to the safety or risk to life of especially the child, then you have to involve the safeguarding team. assess the social situation, as we said, assess the support, anybody else she can confide in with, other family members. So find out whether a child is involved, not in this case, but in cases when the child is involved, you have to find out whether the child is also a victim of the abuse. You have to be very sensitive in the questioning. Talk about women's aid. These are the organizations who would help women in these situations of domestic violence, which can be physical, mental, or sexual in nature. Contact information, there's a 24-hour National Domestic Violence Helpline, Abuse Helpline, which you should give a contact for, and then safeguarding team of the hospital. So domestic abuse in pregnancy can manifest first time in pregnancy in many of the cases, and it is very common, like 1 in 4 women, as Dipali already said. Important thing is, during COVID times, it is believed the domestic violence cases have increased because of all the stresses, people losing jobs or whatever. So the incidence has gone up. So that may be one thing which might appear in the exam. So the risk to mother can be infection, preterm labor, there can be miscarriage, injury, even death if it's very serious, stress and anxiety, and there can be growth restriction in the baby if she's subjected to, to prolonged domestic violence. Yeah, so Anila, yes, you have to write. Of course, you will write it in the hospital notes because the next person who sees her should be knowing. The GP, whether the GP has to be involved or not, again depends on the patient. Because sometimes they may be worried that the GP is close to the husband or the partner, and then the information can go out. So GP might not be involved. So that you have to talk to the patient about it. So because the GP may not, unless the GP has brought out this issue of domestic violence and GP already knows about it, you would not disclose it unless she is okay and she's agreeable to it. Okay, so that finishes the domestic abuse, and it was a good discussion. Thank you all of you for your inputs, and let's go. I think Ahmed was the one who raised hand. Ahmed?
Yes, hello.
Hello, so you are okay for the next scenario?
Yes, I'm ready. I think
Okay.
I'm ready.
So that's fine. We are never ready. That's okay. That can happen. So where are you from, Ahmed? Where are you
I'm
talking
from
to us
Egypt.
from? Okay. Welcome to this session. So we have another kind of hidden agenda. Not that hidden, but it's not about finding the hidden agenda. It's about getting the history and then managing the patient. So we will go to the next station for you, and I will put 2 minutes on the clock. Okay, your time starts now.
Okay.
Okay, 10 minutes.
Okay. Hello, I am Dr. Ahmed. I am the registrar responsible for your case today. I believe that you are Miss Rita Skeeter.
Yes, doctor.
And how old are you?
I'm 25.
25. Okay. How do you like me to call you?
You can call me Rita, doctor.
Okay, Rita. Okay. How have you been? How are you feeling today?
Oh, I'm feeling very, very stressed, doctor. You know, my delivery was so problematic. And still I'm having so much pain.
Oh, I'm sorry to hear that. Would you tell me the details of your delivery? Why was it stressful?
You know, doctor, I started my pain and I got admitted. And then the labor was like never ending. And I got epidural, but still I kept having pain. And then I kept pushing and pushing and could not deliver. Then doctor said they had to apply instrument, you know, that forceps, and then they had to pull out my baby, and my baby is also not well. So, and then this pain is not going. Then I had a tear, and then I had to go to the operation theater. Everything happened to me, doctor. I don't know. It was very traumatic for me.
I'm very sorry to hear that you have gone through such a traumatic experience. Let me know more about the pain you are feeling now. Are there any other symptoms you have been going through?
Yeah, this I have pain in my stitches. They gave me so many stitches, doctor. I have so much pain there. Because of this pain, I cannot even sleep at night.
Is there any problem with your urinating or defecating?
So I feel some burning in my stitches when I pass urine, and they've given me some liquid, so I'm getting loose stools.
Okay. Tell me about your baby. How's your baby doing?
So my baby is still in the NICU. You know, I've come to check on my baby today. Baby is also not well.
I hope he gets well soon, and I hope this experience is going to be good very soon. Uh, are you experiencing any bleeding from your vagina?
Bleeding is now become little okay. Bleeding not heavy now, doctor.
Okay. And any other thing that you have been going through, any other symptoms or anything that you have experienced?
I didn't catch your question, doctor.
Are you experiencing any other thing that you have been complaining from? Any other complaint?
No, only this pain, and then I'm so tired. I was so tired in labor, and I still feel so. I don't feel like doing anything. And then my baby is in the NI, so I don't know how will I take care of the baby in this situation. I don't know what to do.
Have you been sleeping well those last days?
No, I am not.
Any bad thoughts or feeling blue?
Yeah, I'm not. I don't feel like, you know, anything is not good now. You know, I don't know. I don't know, doctor, what to do actually. You know, I don't have any idea.
Yeah, actually, I'm sorry to hear that you have been through a bad experience. Let me first let you know that we should, or you may have psychological cancer to support you these days. I think
Psychologist,
that,
doctor? Why do I need a
yeah,
psychologist?
I think that what you are complaining from might be exaggerated by being in stress, and it's always good to find help. And might be that your baby in the in ICU is adding to this stress. So I think it might be useful if we have gone through some psychological support.
Okay. Okay.
And for the pain, I think we shall prescribe some painkillers. I know it will last some time, but with the painkillers, I think it might be get better. Uh, Also, we have some leaflets about postpartum depression. I think it might help. You feel safe at home?
Sometimes, I think uh, I feel that I would not be able to take care of my baby. That's what I feel.
Yeah.
I'm safe at home. My husband is so supportive. He has been, consoling me, and he's also getting so much stressed about me. But I think
Yeah.
I would not be able to, perform my duties as a mother. That's what I feel, and I don't know how to get out of this.
Yeah. I'm happy to hear that your husband is very supportive, and I want to assure you that getting some help is always useful, and it's okay to ask for help to get assured about how to deal with the baby, to how to pass those stressful days.
But why this? You're saying I need help, but why this has happened to me? Like, would they give me any medication because I want to breastfeed? When my baby comes out of
Actually,
the NICU.
actually, the details of the support will be discussed with the psychological counselor. But generally, I think behavioral therapy or sessions with talking and expressing our fears will be initially started. After that, I think that any medication, in case if you need any medication, will be regarded that you are breastfeeding.
Okay. Okay, doctor.
So,
So, what? So you'll give me something for my pain, and you said I should see the psychologist. So, when can I meet the psychologist?
immediately we can book an appointment, okay, for you. And if you'd like to include your partner, that would be good too, to start addressing the issue.
Mm-hmm. Okay. Okay. So I should come back for the appointment, doctor.
Yes. And here's
Okay.
some leaflets. And if you also have any bad thoughts about harming yourself, there is a hotline about help. You can take it.
I did think about harming myself once, but that thought passed away, thank God. But yeah, I hope I don't have that thoughts again.
I think if you have thoughts about harming yourself, it might be better if you get admitted with us for some time.
Sorry?
I think if you might have any thoughts of harming yourself, that it's better to you get admitted with us sometime.
Okay. Okay,
Is it
doctor,
okay with
if you
you?
think so, because my baby is also here in the hospital. I think you can. Okay, I should be okay with that, doctor, if that helps.
Okay. I'm glad to hear that this is okay with you.
Okay, doctor. Okay.
Okay. Do you have any
Okay.
other concern?
No, doctor.
Thank you very much. I hope you have a good day.
Okay. Okay, around 47 seconds remaining, but it's fine. So, Ahmed, how was it? Difficult?
Yeah.
Yeah, it is. I agree with you. It is not easy, though. It is very. That's what I'm saying. There's nothing in the diagnosis which you cannot make. You can make the diagnosis, but it is how you talk and how do you ask questions and how do you explain to the patient that's the communication. So it's a purely communication station. It's nothing in clinical knowledge here, actually. Very less clinical knowledge. Major part of this station is the communication. And as I'm writing in my stations, the lay examiner is going to be sitting here in this kind of stations, definitely, because it's more about communication, correct? Okay, let's, good attempt. Let's go to somebody like your friends here, and I would ask them first. Okay, so here the role player had to tell many things, but let's see. So somebody else now who hasn't spoken. Anila, I'm just asking randomly. Anila.
Yes, I'm ready to speak. Yeah.
Hi, Anila. Hi, where are you from?
Yeah, I'm from Pakistan, but right now I joined you from Canada.
Oh, Canada. Okay, welcome, welcome. So it's morning there. I'm exactly 12 hours from you. Exactly 12 hours. Amazing. That's amazing, actually. Yeah, Anila, tell me, what are your comments on Ahmed? Like, you give positive points, negative points. What would you like to add? Tell me.
So it was a brave attempt on Ahmed's part, and it is always easy to give critical comments when you are not yourself on the hot seat. But I would say that we need to have some energy and some quick questions about the template of the postpartum, because she's coming after 9 days. So after the introduction, we ask her, let her speak, what are her concerns, what is she expecting out of this consultation, how did the experience of the birth go, and then she will open up, she will tell something. And then our concern is like, we understand it's a stressful situation and we feel sorry for the experience that she had, but was it her first pregnancy? Like, information gathering is there, a brief summary about her obstetrical history, and tell her that unfortunately, and about the size of the baby, has she any idea, has she seen the baby, and if she's not breast, did she get the opportunity to express the breast milk, and are her breasts sore, and then about the third degree tear, what are the symptoms, the residual symptoms that she's having, and was she given, what instructions was she given at discharge, has she been following those, then I will arrange, if she hasn't seen the baby, and I will, like, of course, empathize with her and arrange her a meeting with the neonatologist to explain the baby situation, and I will look into the notes. I will assure her that we will try our best to take things in a smooth and better way for her and for her baby, and in between asking questions from her, what questions are coming to her mind, and how I can make things better for her, like support at home. Again, if during the conversation, like if she feels low, like I must ask her the two questions that how is it affecting your emotional aspect, because of all this that you experienced, and if she comes up with the red flag sign that you mentioned, then I should tell her that we can refer you to the special doctor who's trained to deal with such situations, like the perinatal
So what is
mental
that
health
special doctor? Anila, what is the, the perinatal mental health specialist? So I was waiting for that name. Okay, good, good. Okay.
Mental health specialist. And then if the need is felt for her to be admitted, then we have a sick care baby unit system where the mother and baby can be together if the condition of the baby allows that. So these are the type of things, like of course mentioning the leaflet and her concerns about the next time. And if she has residual symptoms, then we can arrange her referral with the colorectal surgeon as well, and follow up and with the perineal tear clinic. I think there's a clinic for such selected cases where anal ultrasound and periometry is done. So these are the things mainly, as you said, the compassion. So in the information gathering, the typical template of the postpartum history wasn't followed.
Okay. So specific to, okay, first you gave one term, that is the red flags. So what are the red flags? She was giving one of the red flags already. Already she was telling the same again and again. So what are the red flags we consider in a mental health case? mental health scenario, maybe antepartum or postpartum? What are those?
So the red flags are that the patient's behavior changes. Either the patient becomes hyperactive or the patient becomes aloof and withdrawn. It can happen in the antenatal or postpartum, and the patient starts having fixed ideas that somebody is going to harm me, somebody is going to harm my baby. They might start seeing shadows, which are called hallucinations in the medical terms. And then postpartum also, they might feel like harming themselves or harming the baby. And it could range anywhere from mania to severe depression. So there can be like positive symptoms and negative symptoms. So these can be the red flags for which we have to refer them to the perinatal mental health.
Okay, good. Thank you, Anila, for all your points. So,
Thanks a lot for giving me the opportunity.
No problem. I would give opportunity to everyone, but little difficult. But let us see. Ayan, welcome. Ayan.
Yeah, actually, while you were giving the history, there were two things which were important. You were saying, first thing was your post-traumatic delivery experience. Second thing was lack of sleep and your stress and anxiety that you was not able to concentrate. And the third thing, you said that I do have feeling of harming myself. And the another thing that you were feeling lack of bonding with your baby, and you were thinking that you were not be able to act as a good mother. These are all the red flag signs which need immediate attention. Lack of sleep is a factor which can aggravate the condition, and she needs attention, psychological support, and mental health team right now. Because this can lead to her towards the psychosis and other things. So we should address that. And besides that, in this station, we have two issues. One was the perineal tear, and the second thing was her mental health status. And I was perineal tear was concerned, I was thinking that we should have offered her examination so that can see because you said that I have burning at my stitches, so we should see that if she has any complication, any discharge, or what is the healing process going on. And for that, we should address that. And as far as her mental health, we should offer her straightway admission. And she was saying that she wants to breastfeed the baby. We have to offer her the mother baby unit, because that is the place, if the baby's condition allows, that she can stay with the baby and she can breastfeed, and there will be increase in the bonding. And obviously the other factors which will be besides that, I was thinking that we should have asked her about her previous mental health history, as well as any family history of mental illness.
That's a very good point. Actually, this patient has a sister who had depression. So yes, the family history is very important. And then positive family history, all know that increases the risk of them getting antenatal or postnatal depression, correct? Very high chance, like 1 in 2 to 1 in 4 chance of getting depression in this pregnancy. So
now, these were the things I was thinking that I should discuss. Thank you.
That's very good. So again, good important points. And the patient is giving you history. I don't feel I'll be able to take care of my baby. She later on came out with the point that I have always also thought about harming myself, which was not asked, which should specifically be asked when you are thinking about mental health disorders. So yes, that's another point. So again, in this scenario, we have two things. Postpartum patient. Anybody else wants to add before I start speaking? I would like, okay, who is 1 plus 7? I don't know who's 1 plus 7.
Yeah, it's me, Dipali again.
Dipali. Why don't you write your name there? Huh?
Okay, that's right. I forgot actually. So
okay,
everybody added beautiful points. I just want to add one point. The moment you said that I think I'm not being a good mother, I think the first answer should be that please don't believe that. I believe that you will be an excellent mother. I think this point, this line should be added just to be
okay.
sure.
One thing I just remembered. In your case, I said maybe I am to blame. So you should respond that it's not your fault. I just remembered. I remembered when I was doing the session. So yes, that's important. So you should remember, you said that this is a common thing which many women face during pregnancy and delivery. I'm talking about depression. So we always, if something you have to explain, I think it's a good idea to go to the third person. You say that many women face that, like you are not alone, correct? And then of course, then you are going to give support, and it's not your fault. It's something which happens to many women.
Yes.
Okay.
Yeah.
Yeah.
Same
So I
thing.
just remembered your point. So I gave you another feedback now.
Thank you.
Okay. Somebody raised their hand and I just missed the name. Who raised their hand? Entisar. Entisar?
Yes, ma'am.
Hello. Hello. Hi.
Hello, ma'am.
Where are you talking from?
From Egypt, ma'am.
Okay. Welcome. Welcome to the session. So yes, what do you want to say?
I'm sorry, ma'am. I just want to ask a question about what is the difference of post-traumatic stress disorder and a case of genuine depression or an anxiety? I mean, is it a post-traumatic disorder which is being translated in the form of an anxiety or depression, or it is a temporary state of depression or low or bad mood or low mood, and I can't know the difference. I want to know the difference.
How does your management change? How will your management change if it's just post-traumatic, which is temporary, or it is actual depression which has been there? Does your management change? If she's saying, I want to harm myself, she's raising the red flag. Does your management change?
No, ma'am, it will not change. But sometimes the role player says something that she doesn't mean. I mean, it is not genuine inside her. She feels that, but she will not do anything.
That doesn't matter. If the patient says, I'm going to harm myself, you have to take it at face value. You know, you'd rather be safe. You cannot.
Yes,
you cannot,
sure.
You cannot assume.
Ma'am, I have to.
You cannot assume that they might not be actually depressed and then they're just speaking out. She's giving you clear indications that something is wrong. She had a very stressful delivery. The question was not asked, but she has a family history of depression. A baby is also in the neonatal unit, and she's saying that, okay, I don't know what to do. I'm not okay. I am feeling like I can harm myself. You just have to admit her. You have to treat her as a depression case. And if she has other symptoms like symptoms of hallucinations, delusion, it may be just a postpartum, even worse, it may be postpartum psychosis. A postpartum stress disorder may trigger depression as well. How can you, in one meeting, okay, just let me finish. So in one meeting, you cannot distinguish everything. You are anyways going to refer her to a psychiatrist who will be a better judge of things, correct? You are going to refer to a perinatal mental health specialist. Your job as an obstetrician there, when you're sitting in a postnatal clinic, is to find out, see the red flags, admit her, and make the diagnosis that something is not going okay. She's having some depression, and then treat her. You're not going to even start medication for her right now. You are going to refer her to a perinatal mental health specialist. You decide right now, she's showing red flags, I'll admit her, and then the psychiatrist has to come to see. You cannot diagnose the psychiatric disorders here. I don't know how to diagnose psychiatric disorders. But what you are going to do is to screen that person whether she has a issue, she has a mental health disorder which is likely to be a threat to her, and then you admit her.
Yeah, but actually we cannot clinically. I know I am going to refer her for the specialist. I'm not going to treat her, but there is something that I could differentiate. It is a post-traumatic stress disorder, something temporary, or it is something serious like that. I know from the symptoms, yeah, but especially if there is no history, no past history.
Okay, let me get back to you. So how does it matter to you right now? See, in an exam, this is the first time you are seeing the patient. You have 10 minutes to diagnose and to explain her management. How does it matter whether it's a post-traumatic, it's a temporary, or even if it is temporary, right now she needs some treatment. Whether it will stay as depression is for later. It is not for your station right now. You have to decide. Even if it is temporary and right now it is serious, the management remains the same. The examiner is not going to mark you whether you have distinguished between anxiety, depression, and a post-traumatic disorder. The examiner is going to mark you whether are you able to detect that she has a mental health issue and she needs admission and she needs treatment, and who is going to see her. I mean, the perinatal mental health team. Who are the people who are involved in that? You are assessing her social support. You are communicating well to her. That's how the session goes. In exam, and please remember, this is for everyone. The MRCOG Part 3 exam is not just to test your knowledge. And this is not a Part 2 exam and you have to go deep into the guidelines or to read between the guidelines and answer the EMQs. you are given a task and there is actual patient there. So it's same as if you will have a patient in your clinic. It's the same thing. You should deal exam as you are dealing with a patient in your clinic. And then how will you manage her? At this point of time, if I see patient is going under depression, whether it is temporary or permanent, it doesn't matter to me. I have to manage her now. And how I manage her now is I admit her, I refer her. She might require medication right now. She might not be just respond to psychotherapy and all. So I would say that you can tell her that you might need to medication, but I'm not going to prescribe medication. I'm not going to tell you need medication, but we may decide to give you some medication to make things better.
Okay, ma'am. I'm just asking for myself how to there is any there is any limit between both conditions. This is a post-traumatic stress disorder, or it is actually depression or anxiety or such a thing are post-traumatic stress disorders.
So if you have to distinguish between anxiety and depression, then you have to, give a questionnaire. And simply I am saying, I don't know, because I am not a psychiatrist. I don't know what is post-traumatic stress disorder, how to distinguish from this depression only with the information that is given to me. And frankly,
okay,
it doesn't matter. It doesn't matter at all to me. It should not matter to you at this point of time when you are going to do this station in the exam. Okay, ma'am. Thank you very much. Thank you. No problem. Thank you. I think somebody was asking about the sleeping pills and all. See, you are a ST5 gynecologist there. Why do you want to prescribe a sleeping pill? Sleeping pill is also it is a antipsychotic medication, correct? It may be for depression or it may be an anti-anxiety thing. You give it to the specialist. So the idea behind the exam is how much you can do and what you should not do. That's also very important. Where do you find your limits? If you say, I will now start prescribing her antidepressant, that may be actually against patient safety. Why am I going to prescribe her antidepressant? So you have to be very careful what we are doing. You have to please remember. Now it's something as a general rule. This exam is about the smartness and strategy. So you should spend your time, spend your energy and all your effort into preparing smartly for exam. If you want to gain knowledge about things, you can gain. But right now you are having an exam in November. So many of you will be appearing for the exam in November. So prepare smartly. You have to do the station. You have 10 minutes. Never waste your time in things which are not going to fetch you extra marks. If you try prescribing, you say that I am going to prescribe you antidepressants. That's not correct. You are not going to prescribe her antidepressants. You should know the team which is going to look after her. And if I go to Asya has written some answer. Asya, are you there? Can you speak up? Asya Khan? I will come to the...
Hello.
Hello. Hi.
No, actually, I just want to see second slide because I joined late.
What second? There's nothing in the second slide.
No, because from the first slide it looked like difficult to understand. Because first I was also thinking maybe it is a follow-up or third-degree perineal tear. So that's why I want to see the second slide.
That's the hidden.
Yeah.
So we are discussing hidden agenda. That's the hidden thing. You have to bring it out.
Okay.
The patient is. I was acting so well. I was crying there and sitting with my head like this. That was hidden agenda there. So it will not be given in the station. So the scenario she has come with is perineal tear, and first you will think it is perineal tear, but then you have to make out, you have to decipher what is happening. Correct?
Yeah, thank you.
No problem at all. So, okay, the Siam has a question about how we take history of delusion and hallucination. Okay, so let us go to now the history taking in when you think it is a depression, what you have to be asking. There is a very good article in the talk, which I think I will post on the general group there, which is about perinatal mental health, how to ask the questions. So what I will speak now, I've written something. When I was studying for the exam, I made some notes about the same thing, what to ask and how to ask these questions. So I'm going to read the same thing. Later on, you can go to the talk article, everything. I've taken it from the talk article. So when you start asking, so I will give you a list of lines or list of statements. You might not use the same statement for all the patients. Okay, it will depend. But these are the statements you can use in this kind of station. So let's see. So how are you feeling at the moment? How your mood has been lately? What is your concern and anxiety? So always ask, what she is actually worried about. So here she's mainly worried about her baby, that she will not be able to. So when you ask these directed questions, the answers come faster. Then your sleep, appetite, okay, energy level, and then the questions of, are you finding any enjoyment in things? Now, to answer your question about hallucinations and delusions, generally what is described in the talk, and it's a good line. Have you had any unusual experiences lately? Okay, so then that can trigger out the answer. Then when you are explaining, now the patient says why it has happened to me and what why I'm feeling like this. So you can say that pregnancy. So that's, as I said, talk in the third person. Okay, so pregnancy, childbirth, and looking after a newborn baby can be a very difficult time in a woman's life, and many women like you go through these stressful responses, and it is common for women to feel anxious and low. And in your case, because you went through a very traumatic experience during your delivery, I can understand why you're feeling this. And sometimes it becomes very difficult for women to cope with this kind of situations. Okay, and this can be a question when it's an antenatal case. Also, you can be asking the patient when you think that the role player is very vague or not replying or not meeting your eyes. So then it can be again a domestic violence or abuse, or it can be a depression case as well. Then then you can say that in these, it's a very common thing many women face, and we can provide help and support. Okay, so you have to assure that we are there with you, and we will apply that. And then when you are going to ask about self-harm, you should specifically ask about self-harm, not waiting for the role player or the patient to talk about it. So you say that as I know it's a very difficult time for you, I want to ask you a question which might seem very intrusive to you, but at any point of time, have you felt or you have had any thoughts of harming yourself? And then, or the line which they give is that some women I meet experience thoughts of harming themselves or others. And in all these scenarios, all these cases, we can provide help and support. Have you ever had such thoughts? Be clear. So signpost, many women are going through this. I know it is a very difficult time for you. And some women may have this kind of thoughts in which they think about harming themselves or others. So have you had these thoughts? And then if you ask the specific question, the role player says yes, then you have to ask further. It's not that you just stop, okay, harming yourself, okay, I will admit you ask about her. How have you thought that you might go through it? And have you ever planned to harm yourself? How are you going to do it? Then she may say, no, I never planned, or I planned I would hang myself or something. Then it becomes more and more serious for you, okay? So then you say that then you have to explain her that, since you are having these thoughts, I think it's something serious, and I think you need help. I would like to admit you now, okay? And I would refer you to the perinatal mental health specialist who's specialized in dealing with women going through these problems. And then they might, after assessing, they might start you on some medication which will help you. I will also refer you to a counselor who will come and talk to you and help you to deal and cope with your situation better. Are you okay with that? Okay. And then if the baby is at home, then the baby can be admitted. Here, in this case, the baby is already in the NICU. So I know you're worried about the baby. And then it was rightly said by Anil, I think, that have you seen the baby? If you want, we can talk to the baby doctors who can come and talk to you about the condition of the baby, and they will keep you giving information. Okay. Then specifically ask about the other thing. How is the bonding with the child? Even if she does, in this case, patient was telling multiple times. Okay. So you still, if she's not telling you, you should ask that, how do you feel bonding with your child? Have you got any thoughts about feeling incompetent as a mother? Because that's an important sign. That's again a red flag. Okay. So these things we should specifically ask. For delusion and hallucination, unusual experiences. Okay. Or you're seeing things which you think they are unusual. Seen or felt things which are unusual. So that is a trigger. They said, yeah, I'm thinking that somebody is coming to kill me or something. Then that means she's having some delusion. Or I see some person there or this thing. Then you feel that now she's going into psychosis, immediate admission, antipsychotic. Okay. Red flags, as correctly said, recent or significant change in mental state or emergence of new symptoms coming up, new thoughts or acts of violent self-harm, new and persistent expression of incompleteness as a mother and estrangement from the infant. And then, once the patient starts speaking, we say that, so these are the red flags. These red flags you just admit and you have to start treatment immediately. Then other lines which you can use. I'm sure it's difficult to you to open about these things, but it is good that you told me about what you're feeling, and I'm sure, and then I am going to help. I and the team is going to help you. Now you should remember, this might also, the perinatal mental health also can come as a structured discussion. So you should know who are the team. What is the team that looks after these people? So it is at the hospital level, the obstetrician, the perinatal mental health specialist, and there is a perinatal mental health midwife there. Also, they're very important. If suppose you're not admitting the patient and they go back home, then there's a team in the community which is going to look after the patient. The GP is involved. There are health visitors, as I told earlier. There's a local mental health crisis team. There's a mental health midwife at the community level. So that's very important. And give them numbers. Okay, these are the numbers you call. And you say that, please provide these numbers to your family members. And you can ask, to come with a partner or the family members next time, so that, they also, because if she is going into psychosis and all, there's somebody else to bring her to the hospital. And then you give out online resources about leaflets and all. If she's going back home, this kind of patient I will just admit. Okay. So there are duty psychiatric nurses in the hospital with our on-duty hours, and there are liaison psychiatric nurses who are out of hours. So they are always there in the hospital, who they can call in case of any emergency. And the inpatient treatment, what are the indications? Any evidence of any psychosis, it means delusion, hallucinations, just admit. New and persistent beliefs of inadequacy as mother, pervasive guilt or hopelessness, significant estrangement from the infant. Now, this lady doesn't have estrangement from the infant. She's worried about a baby. Sometimes they may just not care. Or the husband comes and says that she doesn't want to touch the baby. She's not taking care of the baby. Then also it's a red flag for you. And suicidal ideation of any kind, rapidly changing mental state. And their admission is to the mother and baby unit. So this is how I would deal. Just few points. Quickly, assessing the patient concern and addressing them. Or in this case, whenever a postpartum patient comes, how's your bleeding? How's your pain? Any discharge? Any force-making discharge? Any fever? These are usual things. You should ask them. Okay. Examination for the height of the uterus. Look at the stitches, because she has a 3rd-degree perineal tear. What she's taking is she already told she's taking some laxative, but is she compliant to medication? Has she taken the antibiotic? And then arrange a meeting with the urogynecologist or the perineal surgeons who are going to assess the strength of the repair. That is later, maybe 3 months later. Pelvic floor exercises, these just general things about the perineal tears. Then dealing sensitively with the mental health issues. Empathy, very important, deals with the fear of patient regarding care of the baby. Reassurance about support from the hospital. Relevant obstetric history. So what happened? And then Ahmed asked about the trigger events which triggered this kind of situation. Of course, there may be an underlying thing. You have to ask, is there any previous history of any such problem, family history, which is very important. That's then severity. Severity is asking about self-harm, about bonding with the baby, and delusion, hallucinations. Assessing the red flag signs, as we said. Clinical knowledge, you should know about mental health problems which can happen in pregnancy as a cesarean. Counseling about medications, we say that most of the medication is safe in pregnancy and breastfeeding, whatever they will give. and it's always a risk versus benefit. Options for treatment. So it's not a very severe case, and may try, psychotherapy and facilitated self-help. But of course, this kind of scenario will require antipsychotic, antidepressant medications. Perinatal mental health specialist is the team. You should know the name and use the name, knowledge about the multidisciplinary team and the members of the team. Please remember the members of the team. Risk factor assessment. How will you do? Patient safety, assessing the concern, knowing and counseling about side effects of medication. Counsel about the risk of not taking treatment is very important, because there may be a scenario in which a patient comes antenatally, she was on antidepressants and she stopped in pregnancy because she's worried about risk to the baby. So you say that she should not stop on her own unless discussion with the perinatal mental health specialist, because stopping the medication can cause more harm than benefit. Okay. Safe management plan, and then it includes the mental health team and assessing the red flag symptoms. So that's from me today. I hope this session was useful, and I had a very good discussion with all of you. I'm so sorry I could not involve more people, but I think all of you participated in your own ways. Many people have posted on the chat. I could not read all the comments, but I've been reading some comments, and I hope this is helpful. I have somebody from my course here, Seher. So before the team talks about the course, so we are going to start a course for the November Part 3 exam. Seher?
Yes, Dr. Pooja, good evening.
Hi, good evening. So Seher is in our course, and you can say 2 lines about the course so that other people, if they want to join, they can join us. So anything?
Yeah, Dr. Pooja. Yeah. Actually, it's very comprehensive, very excellent course. I joined first time I took this course, and I'm very happy with all my mentors. They are fantastic, really. They are very fantastic. Any question, any help, 24 hours, I keep them disturbing. And whatever your queries, they are very useful. All targeted points, all station, any recent things ongoing, any free webinar, any help you want. Really, I'm very happy. It's honestly, it's my honest opinion. Even I'm not finding to collect all the course and read it very well, but they are excellent. It's really.
Thank you so much, sir. So I think instead of us speaking about it, it's amazing that to get this feedback from one of the students, and I'm sure all of you are preparing very hard. You're doing a lot of hard work, and I have been in your situation some point of time. And
let's see, Dr. Pooja.
Yeah, thank you, sir. Thank you for your comment, and greatly appreciated. Yeah, thanks.
Thank you,
so all of you are doing good. You are working very hard. I'm sure many of you will be disappointed that you're not getting, it's difficult to get a seat in the exam. I know that we have all, all of you, some of you might be feeling that frustration because of the situation all around, but you should have that patience, and I hope there will be new extra exams coming up from the RCOG. So you should be ready so it should be a continuous sustained preparation from your side. You should start, keep practicing some way or the other, every day or every other day with a study partner. That would be a good idea to keep practicing. Those who are preparing for the November exam, I think now is crucial time, the final stages of preparation. So you should give your best shot. Of course, most of you are working, taking care of your families, work, and so many things, as we all are. And sometimes it becomes difficult. You may feel in between, you may feel stressed out, depressed that, I'm not able to do as much as I should. But I tell you, the exam is always simpler than the practice. So keep doing, have that patience, very important. Be confident in the exam and it will help you. So thank you from my side. I would hand over to my med exam expert team. They will talk to you about the course. Anyways, whatever free sessions, we'll try conduct more free sessions for all of you, and we will start some activity in the group as well. We are planning it, and hopefully all of us will start. We have 4 mentors, and that's the unique part of our course, that we have 4 mentors. So you have different points of view from everybody. So I have myself, then Dr. Mohammed Hassan, who has been a mentor with me for a long time. Then Dr. Zab Qureshi, Zab from the Facebook groups, and she has been part of teaching and discussions for a long time. And Dr. Alina also, Shirazi has also joined us in this course. And so we are a strong team of 4 mentors, and different mentors will give you different insights and different points of preparation. So if you want, the team will now talk to you about the course. You are welcome to join our course, and I would love to see some of you in the course. Thank you all for joining. Thank you all for your input. Thank you. Over to you.
Excuse me, Dr. Pooja, just one sentence only. Hello.
Thank you so much, Dr. Pooja, for this wonderful and informative session. It is always lovely to hear your voice. So I'm sure all the participants will also agree with me. So unfortunately, Dr. Alina will not join us today due to an emergency in her family. So let me tell you about our course. So we have started our crash course that is starting from 20th of September, and the duration of this course will be 1.5 months. The mentors of this course will be Dr. Pooja Sharma, Dr. Zaid Qureshi, and Dr. Alina Shirazi. Now let me tell you about our course mentors. First, Dr. Pooja Sharma is a lead mentor of MRCOG-3 course. She is working in NUH Singapore, and also she is the author of 3 books. Dr. Zaid Qureshi is our senior tutor for MRCOG, MRCPI, APCOG, FCPS courses. Also, she is RCOG examiner. Dr. Alina Shirazi is also a well-qualified tutor of MRCOG, FCPS, APCOG, MRCPI, and she is currently working in NHS. Now, let me tell you about the features of this course. So in this course, you will learn how you will get through the task by discussion on all the domains. You will get to know about different tasks. You will be performing homework tasks that will be monitored by our expert mentors. You will be exposed to more than 100 tasks altogether, and we will get 18 candidates. So don't waste your time and join our course. So this is the schedule for our course, where we will discuss all the difficult topics. Now, here is the gift for all the participants out there. We are offering $100 off if you will join our course now. This offer is valid for 24 hours only. Now, how you're going to apply, get the discount? You have to apply the coupon Active100. With this, the course fee, that is $600, will be changed to $500 only. So these are some of the feedbacks from our course mentors. We will be taking only 18 seats, so register yourself right now. Now, how are you going to register for this course? Let me tell you the steps. First of all, what you have to do, you have to sign up to our website. After signing it up, you have to click on course catalog. From the course catalog, you have to select MRCOG-3 APCOG-2 Crash Course November 21. After this, you have to click on Get this course. Then you will get the screen. You have to apply the coupon Active100, and then you have to click on Validate. After clicking on Validate, the course fee will change from $600 to only $500. And then you can proceed with your normal payment layout. So if you have any query, feel free to ask us. Our backend team will be there to guide you. Thank you so much.